International Journal of Health Policy and Management. Quality and speed are our culture and the keys to our success. Welcome to the audio summary section of the International Journal of Health Policy and Management.
Hello, my name is Nadia Cobb. I will be presenting an overview of a commentary by Dr. Gilles and myself in the International Journal of Health Policy and Management. Our commentary is titled, A New Generation of Physicians in Sub-Saharan Africa. This was in response to the Ayal and colleagues' editorial, Non-Physician Clinicians in Sub-Saharan Africa and the Evolving Role of Physicians. It is well recognized that the low numbers of physicians, as well as their distribution in resource-poor regions, including Sub-Saharan Africa, cannot meet the needs of the population. More than 50% of the world's population live in rural areas, with only 23% of the health workforce available to them, as reported by Shail Adlon in the International Labor Organization. Ayal and colleagues state, all health workers must work together to deliver high-quality health services. Major changes to one component of such integrated systems require complementary adaptations elsewhere. They go on to discuss the implications of the emergence of the non-physician clinicians on the health labor market for the education of medical doctors. Ayal et al. Are recommending significant reform in Sub-Saharan Africa in the education of physicians to include new competencies such as team management, mentorship, supervision, planning of services, as well as more complex clinical ones, as the non-physician clinicians have evolved into increasing access to care in a more traditional medical model. The literature provides examples of non-physician clinicians, such as the assistant medical officer in Mozambique, who are considered absolutely essential in providing life-saving surgical services in the rural areas. The effect of this is multidimensional, with decreases in unnecessary referrals, decreases in delay to care, decreases in the workload at referral hospitals, and ultimately decreases in cost. This can be seen in the focused skills mix expansion, as well as with retention rates in rural areas. At 7 years in rural Mozambique, the assistant medical officer was shown to have an 88% retention rate, as compared to less than 3 years for the average physician. In our commentary, we post the need for more clarity in the use of the terminology non-physician clinician or mid-level clinician. Ayal et al. Define them as practitioners with an education higher than that of nurses but lower than that of physicians. In Sub-Saharan Africa, these clinicians are most often seen in rural areas and often as the very front line of care. Dovlo, in 2004, referred to substitute health workers, with mid-levels as cadres who take on some of the functions and roles normally reserved for internationally recognized health professions such as doctors, pharmacists, and nurses. He identified 8 countries in Sub-Saharan Africa where these health workers existed. Mullen and Freywat in 2007 used the description providers who are not trained as physicians, but who take on many of the diagnostic and clinical functions of medical doctors. They identified 25 of 47 sub-Saharan African countries utilizing this health workforce. Cobb et al. In 2015 shifted the focus, specifically focusing on clinicians trained in an accelerated medical model rather than a nursing model, as a grouping of cadres that had traditionally been included in non-physician clinician and mid-levels. Globally, these authors identified 46 countries that these cadres increase access to care in, with over 20 different titles. These include clinical officer, medical assistant, community health officer, public health officer, clinical associate, physician assistant, to name a few. The authors use the descriptive categorical title of Accelerated Medically Trained Clinician for these cadres. For clarification, AMTC is how this grouping will be termed for the rest of this brief. In Sub-Saharan Africa, the authors reported 20 countries where AMTCs served as part of the health workforce. Clearly understanding the skills mix of cadres included in non-physician clinicians is critical to identify the expanded competencies for the evolving health professional roles. Campbell et al. Note that in order to integrate caters into health systems and demonstrate the value of their investment, there must be a much more clear understanding of the frontline and community-based health workforce. In many settings, the non-physician clinicians have a high degree of autonomy because of their geographic location. However, this does not mean that they need less support or less supervision, just different than the hospital-based non-physician clinician where physicians are more readily available. In Sub-Saharan Africa, the rural primary care-based non-physician clinicians often run the entire community-based health center with management of responsibilities over staff, ordering supplies, oversight of general functioning of the center and its catchment area, as well as the clinical aspects of providing health care. Educating medical doctors in a manner that exposes them and develops competencies with a thorough understanding of the skills mix that exists will not only support community-based care and its efficacy, but will potentially also ensure quality and safety. In Malawi, the medical assistant, the primary care AMTC, and the clinical officer, the AMTC with skills mix expansion to emergency obstetric surgery and surgery, serve the majority of the country. With approximately only 500 physicians in the country for 17 million people and 30 based in rural areas, the AMTCs have been considered the backbone of Malawi's healthcare. The medical assistant was established by the Ministry of Health in the 1890s, with the clinical officer following in the 1970s. The first medical school opened in Malawi in 1991. Henry et al., in exploring the surgical arena, noted that the clinical officers perform 88% of the country's surgeries and 85% of the anesthesia. Reforming medical education to most effectively prepare future physicians to work with the non-physician clinicians to create a fit-for-purpose health workforce will require policy reform as well. Having formal recognition and definition for the non-physician clinicians, specifically the AMTCs, as non-physician clinicians trained in nursing models are already represented in the International Labor Organization's International Standard Classification of Occupations. Maintaining the cultural and regional variations of the AMTC while setting some standardization should be promoted, for instance, through the World Health Organization working with the International Labor Organization, to ensure that the revision of the International Standard Classification of Occupation include these cadres. This will continue the evolution of the health workforce, maximizing skills mixes to serve the regional and global populations. In considering examples of other competencies needed, we would suggest the addition of at least one competency domain to the original proposed list, the utilization of e-health and m-health. These are becoming abundantly recognized and increasingly used in Sub-Saharan Africa, with non-physician clinicians often being at the front line of healthcare, working alone and often unsupported because of geographic location from larger healthcare facilities within health systems that fail to define clear paths of communication and supervision. Such technologies could increase motivation as well as quality. Physicians born in the age of the internet and future physicians will most likely be able to easily integrate such technologies into their day-to-day practice. Another aspect under leadership and governance to include in physician competencies would be the coordinating and mobilizing of stakeholders within communities, as well as aid agencies, etc. These are very specific skills and skill sets that need to be considered when developing new competencies. In moving forward and looking beyond the identification of new competencies that physicians need to develop, we need to consider health policy issues such as how to build capacity of education institutions that implement reform. Can it be done with existing staff of educators, knowing that they also need to develop new capacity? This while many African medical schools have part-time staff. How can physician training facilitate an understanding of the rural and underserved populations, usually served by non-physician clinicians, in order to better plan and manage services corresponding to the health needs of these populations, as well as providing adequate supervision to the non-physician clinicians? How to communicate between different ministries responsible for the education of physicians and other providers to ensure that skills mix aligned with the needs of the population are focused upon, as well as understanding the skills within each other's professions. Is accreditation of programs and institutions really the best tools to promote innovation and adaptation to the changing labor market and the requirements of new delivery models? Should accreditation cover all health profession education to ensure alignment between education of physicians and non-physician clinicians, nurses, and other providers? In conclusion, there is plenty of evidence that the non-physician clinician can provide quality care to populations with limited access. These cadres should not be considered second-class substitute in resource-poor settings. Rather, they represent a truly fit-for-purpose health workforce that add to the traditional skills mix, even being identified as the backbone of primary care, or, in several countries, increasing access to emergency obstetric and surgical care. The concerted investment in the non-physician clinician can be a response to improving availability, accessibility, acceptability, and quality of health workers. By adapting the education of the future and existing physician to new roles, countries would ensure that they and others work to the top of their skills, and thus health systems would be more capable of contributing to the sustainable development goal of ensuring healthy lives and promoting well-being for all at all ages.